For those of you who do not know me, my name is Chavon Niles. I'm an assistant professor in the Department of Physical Therapy, cross-appointed into the Rehabilitation Sciences Institute in Temerty Faculty of Medicine here at the University of Toronto. I am a critical disability studies, critical race scholar. My research focuses on ensuring that those that are underserved and under-resourced, that we center their stories. I always like to say that as a community-engaged researcher, I'm not saying anything different than what community members have been telling us since the beginning of time. My job is just to amplify what has always been said. So I have the utmost pleasure of moderating this final panel for us this afternoon. And in this session, we will explore how public trust has been strained during recent health emergencies. And we're going to focus on what it means to rebuild that trust through partnership with communities. We'll have some short presentations by AHIP members, including myself, and invited community organizations. Then we're going to have a panel discussion, which will focus on co-designing more equitable, responsive, and trust-driven approaches to future emergencies. I'd like to start by welcoming Brian Baigrie, who is a scholar working at the intersection of public health, ethics, philosophy of science, and epistemology, who has an established research program on trust, uncertainty, and institutional legitimacy. Recent work includes peer-reviewed publications on adaptive trust, public health communication during COVID-19, and the ethics of emerging technologies. Welcome, Brian.
I'll lower this too. I want to thank the IHEP leadership for this invitation. I'm very happy to be part of the conversation. I'm probably the only philosopher of science in this room. How I got here is a long story, but my work was about evidentiary reasoning, and especially the limits of inference. And after teaching in Vic 1 for a little while, I was approached by a faculty member at IHPME to co-design a course, which we called Advanced Topics in Epidemiology. And it was a close look at observational and experimental trials, and to ask tough questions about their goodness and their relevance. And from there, then in 2018, I kind of pivoted to issues around public health ethicists. I'm not an ethicist. I don't know any public health ethicists who've actually had training in bioethics. I mean, most of them have been reclaimed from medicine, philosophy, and other areas. Trust exploded on the landscape, not at the beginning of the pandemic, but shortly thereafter. It became recognized as an issue. And it led to a big about-face, because if you look at frameworks for public health ethics prior to the pandemic, they always list a finite set of principles: beneficence, non-malevolence, autonomy, justice were the four. But if you look at recent updates, it includes transparency, accountability, and sometimes trust. Not a lot of literature trying to show how those things hang together. But what's more worrisome is that, I went the wrong way. Oh, I'm not seeing my slides here. Oh, no. Oh, here we go. Not many of the articles that are out deal with what I call trust gaps. And so today I'm going to talk about trust gaps, and instead of talking about public trust per se and trying to provide a conceptual framework for that, I'm going to focus on mistrust, because not just the perceived, but the measured erosion of public trust speaks volumes, not just about the public's relationship with institutions, but about something that was talked about in the previous session, perceptions of trustworthiness. And so not all trust gaps are communication gaps, reframing trust, communication, and community partnerships. So let me start with the point of agreement. There's no question that communication and community engagement are essential in public health. So efforts to identify communication gaps and build partnerships are essential. I think we would all agree with that. But I want to suggest a small shift in how we think about the relationship between public trust and communication. And what I want to say is that not all trust gaps are communication gaps. Much of our current approach assumes that mistrust arises from failures in communication, but this assumes that all communities are similarly positioned with respect to institutions, and mistrust or hesitancy to comply with public health guidance, messaging, etc., is primarily a response to what people are hearing now. This assumes that all communities start from the same place, but they don't. In my draft of the slide, I called it the original position because my spouse is a political theorist who wrote a dissertation on John Rawls's Theory of Justice, one of the most influential books in modern philosophy. And he talked about the original position and talked about justice in terms of advantages and disadvantages that people had in view of their positions. He was thinking more in individualistic terms, but not in terms of disadvantages pursuant to communities of various kinds. But for today, I'm referring to it as the historical position for disadvantaged communities. Trust is a function of lived experience, not just knowledge or communication. Some communities, Black communities, Indigenous communities, gender diverse communities, populations, the disabled community, could go on, the unhomed community and others, have histories with public health, scientific, and government institutions that can lead to mistrust. And mistrust can be shaped by, and for example, past experiences of discrimination, dismissal within healthcare settings, inequities in access and treatment, there was some mention of those today, and broader institutional histories. And there's quite a lot of literature about that. So let's start with the distinction between two kinds of trust gaps. First, what I call informational trust gaps. These arise when evidence is evolving, as we found during the pandemic, and explains in part the erosion of public trust during the course of the pandemic. When guidance changes, there was some mention about that and the confusion and cost to many members of the public. When people are uncertain or confused, they're more likely to reach out to group expertise, neighbors, and to the internet, perhaps to fill gaps in their information. Here, communication matters a great deal. Clarity, transparency, explaining uncertainty, better communication helps. Then there are relational or structural trust gaps. These arise, for example, when people have experienced inequitable care or expect to be dismissed or mistreated or see institutions as not acting in their interest. Here the issue is not primarily about what is said, but whether the speaker is perceived as credible. In these contexts, what looks like a communication problem is often a credibility problem. So getting the causal direction right for disadvantaged communities. My own work on public trust success, something quite simple but often overlooked in the burgeoning literature that addresses the erosion of public trust. People don't just evaluate messages, they evaluate messengers. Trust often shapes how information is interpreted rather than the other way around. Many people in many studies operate with what I call an information first model. As information first as the input, and the output is some measurable parameter related to levels of trust. I want to flip that entirely. Did I skip something? Now the partnership with communities. So the question is not only how do we as trustees in our relationship with the public communicate better, but also under what conditions are institutional communications perceived as credible. Often partnership is framed as a way to improve communication and as a channel for delivering better messages. But I would suggest a different way of thinking about it. Partnership's not just a strategy to improve communication, it's a condition of credibility. When communities are meaningfully involved, respected as knowledge contributors, and involved in the design and implementation of recommendations that work best for their communities, then communication changes, not just in content, but how it is received. Wrong way. warranted trust. Discussions of trust often focus on the relationship between a trustor and a trustee, but less attention is given to the grounds on which trust is warranted. In context where mistrust is elevated, trustworthiness cannot be reduced to accuracy or transparency alone. It includes relational and institutional virtues such as respect, responsiveness, fairness, and accountability, which has already been mentioned, that are expressed through practice rather than through confident assertion. In such settings, credibility is not simply a function of what is communicated, but of whether institutions demonstrate over time, that's the big variable here, that they're responsive to the experiences and concerns of those whom they serve. Informational trust gaps. With respect to informational trust gaps, trustworthiness is widely conceptualized in epistemic terms: expertise, competence, accuracy, clarity, transparency. These are the sorts of virtues we associate with trustworthiness of trustees. Institutional efforts to ensure the integrity of information have fastened on developing more effective communication strategies and align strategies to address threats to the integrity of the information ecosystem, misinformation campaigns. I keep on turning this thing upside down, I'm going the wrong way. Now to structural trust gaps. With respect to structural trust gaps, communities with grounded mistrust, trustworthiness should be conceptualized in relational and moral terms. So these are some candidates for conversation if we have time for that. Respect, people are taken seriously, not dismissed. There are so many reports of people being dismissed in healthcare settings. Recognition, acknowledging lived experience and lay expertise, the expertise of members of communities, as epistemically relevant. Social listening, not just broadcasting, very important. And the World Health Organization has an interesting initiative on social listening, which was developed and sponsored by Ross Upshur, who's a member of IHIP. Non-dismissiveness, especially towards concerns framed as misinformation. People who approach professionals with information that professionals regard as misinformation are often dismissed, and their views are not taken seriously. Okay, institutional justice. So here's some suggestions for a public facing. So the criteria, accuracy, transparency, clarity, competence, expertise, all that are public health or institutional facing principles and expectations for trustworthiness. But here I want to suggest some principles that are public facing, especially suitable, I believe, when we're thinking about the position, the historical position of marginalized and disadvantaged communities. So here I want to say trustworthiness is not established by institutional claims. We are transparent, we are accountable, those sorts of things, but by repeated interactions in which institutional commitments are made credible and visible. Fairness is at the top of the list. Equity in treatment, it's difficult to achieve, but it's an aspirational virtue. Accountability, and here I want to spell out what I mean by accountability. Too many discussions are about, and people throw the term accountability. I mean, who doesn't want to be accountable? I mean, I'm a parent, I have 3 kids. We all want to be accountable. I pay taxes, I want to be accountable. We all want to be accountable. But I want to specify that it's accountable for past and present harms, right? We don't want to lose track of those harms. Consistency of practice, right? Not just messaging. So the practices themselves have to be consistent. Inclusion, and earlier in our first presentation today, we heard about effective and inclusive communication. So I want to broaden that and talk about inclusion in public health decision-making, co-design, not consultation. So when most people talk about engaging communities, they're thinking about placing members of communities, or at least trusted experts of communities, in the role of consultants, but not in co-designing what sorts of measures might be appropriate given their communities. Right? Repair, this is the most problematic. I don't know what it means, but it's a good word. I'm getting my deck repaired right now, so, and it was clear to me the person fixing the deck doesn't know what they're doing. So what does repair mean? Capacity to acknowledge and respond to failure. We don't see enough of that in the public health side of things. So, many of the initiatives we have are kind of, we had some interesting talks today about, during the pandemic, we heard a lot from journalists about how poorly other nations were doing managing the pandemic. And we heard a lot about Sweden, we heard a little bit about Finland, the UK, Spain, a lot of countries. But that kind of turns attention away, not just about what we're doing right, but what we need to do. And when we look at international comparisons across a number of measures, vaccine uptake, booster uptake, and other things, with the UK, with Nordic countries, not just Finland, but Sweden and Denmark as well, and Israel, who are very comparable because they had similar access to technologies, vaccines, and all the rest of it. We haven't done that well. Nowhere near as well as we think we're doing. And I'm very happy with our performance, but responding to failure will require for us to give a very hard look at how we responded through the last pandemic. And I don't think we've really done that yet. There's a lot of work to be done here. Okay, that's it. Thank you.
Thank you very much, Brian, and thank you for also naming the importance of accountability as not just a word we're using, but something we actually are doing, and something we are also making visible, and the importance of co-creating with community, especially those that were the most impacted. It's my pleasure now to welcome Colin Furness, who is an associate professor in the Faculty of Information. He currently studies the social construction and perception of expertise, and he teaches graduate courses in misinformation, research methods, and professional identity. Welcome.
Being here today feels a bit self-indulgent because this whole research program on expertise is really my own pet post-traumatic stress disorder therapy from having been a sort of a half-willing public epidemiologist during the campaign and been accused of being an expert by some and pilloried by others. And so, make sure I get this in the right direction. Yeah, there we go. That's me. And so I want to talk about the fallibility of experts and tell you about a little bit of the research I've been doing. And I've got one which to me was sort of a shocking / delightful finding to report as well. So we want experts to be authoritative, or at least we say that they are. We want them to be right, and a lot of times they aren't. And when they are, we want them to then to translate that into actions that are useful, and sometimes they're not. And even if they're useful, we want them to be persuasive. And I think it's just building on what Brian had to say. People do evaluate the messenger, right? So this idea of being authoritative to being persuasive, there's a lot of opportunities for the wheels to come off the bus. And I want to talk about some of those a little bit. So we start with the idea of a crisis of expertise. The philosopher Donald Schoen, who I think of as a sociologist. Oh, great, thank you. He talked about how if you were a professional, you just had this high status in the 1960s, that we just had this optimism that professionals had these skills and they were able to solve problems for us. And by the 1980s, the cracks really started to show. And I think it's only gotten worse. And I point to a few things in particular. An inability to deal with novelty, that professional expertise tends to be rearward facing. An inability to deal with complex problems because we train experts to be specialists, right? And to not necessarily communicate well across those boundaries. An inability to make sense of conflicting evidence, which sometimes suggests that maybe there's wrong, maybe there's a misunderstanding here. And the elephant in the room for today, certainly, an inability to respond to social issues, and some of those were named, I think, quite well by Brian. So let's just stop and say, well, hang on, what is an expert, right? And there was a comment made in the session before break. We need to do a better job of understanding what expertise and experts are. I couldn't agree more. We can define it two ways, right? We can say, hey, an expert is someone who knows lots and can do stuff. They know things most people don't. They can do things most people can't. And that's reasonable enough. But it's not the only way to think about experts, because some experts don't necessarily have these. We can think about experts as being more socially constructed. In other words, words, we decide who the experts are socially, and then we decide that what they do must be expertise. And that may sound a little bit odd, but actually, in a lot of ways, that's how experts get anointed. Not because they have passed some exams, but because we have agreed through whatever mechanism that they are to be experts. So either way, if you look at the positivist definition or that sort of objective definition, you need to have as much or more knowledge than an expert to be able to judge if they're experts, right? So we can't judge that directly. We judge credentials, reputation, and so on and so forth. On the other side, on the interpretivist side, we look at people's job role, we look at cultural role, and you know what? Charisma, it turns out to actually be really important for people to get anointed as an expert without any reference to what they know or what they can do. My point here is that trust underpins both. So we don't need to choose which definition of expert we need to work with. Actually, I think there's value in both, but we really can't get away from that. The first conversation I think I ever had with Brian, when I said, I'm going to start studying expertise, I don't know anything yet, and he asked, well, does expertise require trust? And I got the answer right, I think, in his eyes, because we kept on talking, and that was to say, yeah, I think it kind of has to. So yeah, it does matter. So I had a sabbatical year with the idea of writing a book, and I'm taking a second sabbatical so the book can actually get done. I spent a year going down rabbit holes, and I realized that what was needed, what we didn't have yet, was a theory of expertise that could explain expert failure. And so I want to just very briefly explain that theory to you, and then some measurement that I did, because I think this can help inform the conversation. So it's a three-piece model of expertise, and the first piece is straightforward. What I call productive expertise, skills, right? The surgeon who can take out a gallbladder, or the violinist who can play Mendelssohn, that's expertise that you can see. It's performed, it's skills. That's easy. The second piece is analytical expertise. This is knowledge you have in the head, right? So the theories, the principles that you know that are obviously connected to what you do, but help you learn and help you innovate and adapt. So most people, when they talk about expertise, kind of stop here. There's skills and there's knowledge, and what else do we need? Well, it's a three-piece model for a reason, and the third piece that I have added, I call abstractive expertise. And if productive expertise is what you do, and analytical expertise is what you know, abstractive expertise is how you think and how you respond to the environment around you. And that turns out to be stuff that we don't teach in school. So there's some other bits in here too. There's knowledge utilization in that space, which is the ability to do research or to make knowledge useful. There's reflective practice between abstractive and productive. And probably the most important one, and I had to invent a word for it, I'm sorry, it's hard to say, knowledge situationalization. There was no word in the English language that would actually describe what's in that space, which is the ability to take what you know and adapt it to the circumstances that you're in. In other words, being able to read the room. And that to me actually matters quite a lot. And again, the top of the model is tangible, the bottom is intangible. So even if we can all agree that abstractive expertise is a good idea, it's pretty hard to wrap our heads around where do we find it, how do we teach it, how do we inculcate it, and what can we do about it. But I want to break it down a little bit more into some of the dimensions that my research over the last year has uncovered. And there's 6 here. It's not a complete list, but it's mostly here. Curiosity, the ability to frame problems, the ability to do perspective taking. Problem framing is turning a problem to see it from a different angle. Perspective taking is actually seeing different people's different angles on the same problem. Epistemic humility, what does my epistemology not let me do? Evidence-based medicine, for example, is fantastic in terms of what it enables us to do. The conversations that we don't have is what evidence-based medicine prevents us from doing and knowing, and there's a lot to say there. Cognitive flexibility, the ability to change your style of thinking as circumstances warrant, and reflective capacity, which is to examine your own positionality and your own learning and your own involvement in what it is that you're doing. These are important, and they don't get taught. Right? So some people develop these, some people figure these out, some people wield them very well, and obviously some don't. So here's the overall model, just FYI. Adaptive thinking is the top. That's your stance. The curiosity, the flexibility, and the reflective capacity you have. That's your starting point. And we can follow it down the left side and say, well, if you are dealing with novelty, then you have situated thinking. And if you are trying to manufacture novelty, if you're trying to do problem solving, if you're trying to create, then there's emergent thinking. For the research I'm describing today, we didn't pay much attention to emergent thinking. That's still yet to be done. But this is sort of the overall mental model here. And so the first thing that we did was to say, okay, well, this is all very fine to draw these pictures, but how can we actually find some validation here? How can we find some evidence? So the first thing we did was we looked at a raft of research assistants and students who did a lot of work looking at professional competency documentation. So how do physicians define themselves as a profession? And we took every sentence in those competency documents and we classified every single one. And this is what it looked like. And it's pretty darn high and productive. And you know what? I'm okay with it being high. We train professionals to do stuff. They ought to be able to do stuff. But abstractive is looking a little bit low. And we thought, well, okay, let's look at nurse practitioners. And we found the situation is actually similar. Nurse practitioners sort of get more on the analytical side and even less on the abstractive side. And it's not that I mind the 82%, it's the 9% and the 5% that I'm a little bit worried about. Now, we're not describing people here, we're describing documents, right? We're describing how these professions, what yardstick they use to measure competence, right? So this is the ideal. On the other hand, and I've done this with many professions now, social workers, very, very different. Again, productive is still higher, of course it is, they're professionals, but abstractive expertise actually starts to really take up some space. And then psychotherapists, which is my most recent study, we looked at the competency documents and they're even higher. So, and if we put them all together, and I'm sorry for those in the back of the room, this is going to look like ants from 50,000 feet. We've got two clusters here. We've got what I call the curing professions and caring professions. And the caring professions have more abstractive expertise. Curing and caring in the sociology of professions, they're gendered terms. Right, and that's foreshadowing. I kind of want to come back to that a little bit later on, but maybe you can see where I'm going. So, competency documents are fine, but it's my student Colin who's done so much work. I had to put her on display today. She has just finished analyzing the data from her master's thesis, where we developed a gigantic instrument to measure, a psychometric instrument to measure abstractive expertise on those dimensions. And we had two research questions. Can we discriminate abstractive expertise? Can we actually reliably measure these things? Can we do that? And if so, the $64,000 question is, does it increase with experience? Because it ought to. And if it doesn't, I'm not sure we've got something all that useful. So we administered this to 170 Canadian psychotherapists. And there's the model again. Yep, we got all 7. We got them in spades. Actually, it was really, really clear. We can discriminate these characteristics of curiosity, epistemic humility, cognitive flexibility, and so on and so forth. There were some existing instruments out there, and they were all inadequate, so we really did build it from the ground up. We also found that the 3 that measure, that do adaptive thinking, they really correlate with each other well, which is what you might expect to see if they're all part of something bigger. And the same thing for situated thinking. Now this is where it gets a little bit more interesting. Does abstractive expertise increase with experience? We picked psychotherapists because we figured they were going to have a lot of abstractive expertise, so we wanted to start with that to see, well, can we develop an instrument that will gauge that, where we won't find, for example, ceiling effects, right? Where everyone's 7 out of 7 on everything, and therefore you really haven't measured anything at all. And so it was a little bit dicey, but we did find with our sample size, if you compared the most junior and the most senior, yeah, there was a big climb in abstractive expertise, in adaptive expertise, or adaptive thinking rather, and situated thinking. All of them increased with age. So I'd meant to request a drum roll. I think I forgot. There's no drummer here today. We'll have to cope with that. So for the most junior to the most senior, yeah. For those identifying as she, her, it went way up. For those identifying as he, his, it not only started lower, it actually went down with experience. So, the moral of the story is if your psychotherapist is an old man, you might want to reconsider things. Here's the thing, I've got my sample size there. Most psychotherapists are women. We only had 23 men. You better believe we have now gone back and we're oversampling men because we need to see a little bit more. That trend decrease is not statistically significant, but those numbers speak for themselves. With a few more participants, I have no doubt it's going to go that way. I don't know exactly why. But I do know that the so-called caring professions, which are sometimes called feminized professions, are female-dominated. I think we talk stereotypically about women being better at listening, better at communicating. They seem to, they populate professions like teaching and other kinds of caring professions. Maybe abstractive expertise is a quantitative yardstick that actually provides some sort of hard numbers to make sense of that or to explain that. So yeah, they scored lower on everything. Except systems thinking and cognitive flexibility. And who knows, with a larger sample size, that might change too. So where I'm going with this is we have this idea of abstractive expertise, the way you think. Professions, depending on the profession, value that a little bit or not so much. These are the things that allow us to connect what we know with our ability to deliver, to serve populations, to be persuasive, right? To be not just authoritative, but persuasive. So again, if we look back to this list that I started with, being able to deal with novelty, which may sound easy, but golly, we're not training health professionals to deal with novelty. And evidence-based medicine, which I understand really, really well, is an obstacle. It doesn't mean that we should flush it, but we need to understand what those limits are. Dealing with complex problems, and pandemics, health emergencies, are nothing if not complex. Making sense of conflicting evidence and responding to social issues. So if I could get a blob of plasticine and manufacture an expert, it would be an expert who could do these things. And how, what the color that plasticine would be? Well, if we think about these dimensions of abstractive expertise, it seems to me that some of them really connect to dealing with novelty, and I think some of them connect really well with complex problem solving, and I think some of them connect really well with making sense of conflicting evidence, and some of them connect really well with responding to social issues. We could quibble about some of these arrows. There's a lot of arrows here. There's a lot of concepts being connected to each other. But I think it's not a coincidence that we have a crisis of experts not being able to do the things on the left and professions not training experts to be what those things are on the right. Right? So as far as the gender difference goes, it could be that there's just a lot of oafs who get into psychotherapy who are male. Okay, I'm going to do a study, starting a study in August with law students, and I'm going to measure their abstractive expertise at the beginning of law school and at the end of law school. I think it'll go down. Not because I have anything against lawyers, but because this is what professional training does. It narrows your epistemology. It makes you think in one way. And I don't know if anyone here can help me, but I would love to study physicians. I mean, really, 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 really want to study physicians. And maybe in a year or two, I can come back and show you some data that way. But as it stands, it's law students right now. I really want to get to the bottom of that gender question. I want to get to the bottom of, does professional training actually make matters worse? And if that's the case, and I think it might be, what are the sorts of things we can do about it? So my last sentence is, I wish I had a magic formula. I wish I could say, here, take these pills and everything will be fine. I don't. I think what I'm trying to contribute here is to be able to identify what the problem is that needs solving. So I don't come solutions in hand, but I think this is a way to understand what we need from our experts so that when, as Brian said, they're evaluated as messengers, that valuation is positive, right? And it's not about brand. It's very much about the way experts can connect what they know with the limits of what they know, and novelty and complexity, and to essentially be able to be better at situationalizing what they know, to be able to actually read the room and to be able to connect with the people that they're meant to serve. So that's it. Thanks.
Thank you for changing the slide. I appreciate it. Okay, thank you so much, Colin, for getting us to really think about the way we think and who defines what is an expert. Whenever I think of an expert, I always think about who and what is essential and who determines, what is essential, especially during emergencies. I also appreciated the ways in which you helped us to think about the different types of experts. And for me, I'm sitting with the complexity of doing this work and the possibility that comes from all of us engaging in this conversation together. So I'm going to take us in a little bit of shift us in a little bit of a different direction, but it builds on the conversation that Brian and Colin have started today, and it's really to help us think about what does trust look like in our public health system right now. We often focus on communication We look at how do we get to understand, we look at how people understand information, how people are engaging with this information, and how folks are responding. But I want us to think about what this looks like when trust isn't built, from that point of communication. I want us to think about, before an emergency happens, how is trust thought of from people just existing within community? And so I'm going to try to get us to think about that as we move through this presentation today. Public health tends to focus on communication. It tends to focus on information, messaging, and behavior change. Those things definitely do matter, but they assume something important. They assume that people already trust the system those messages are coming from, or the messengers that's sharing this information. What this work shows, what I'm going to share with you right now, is that trust isn't a starting point. It's something that's shaped over time through people's prior experiences within these systems, through whether they've been taken seriously, navigating health, rehab, social services, for example, and whether those systems have actually responded to their needs. So through the support of an IHIP grant in 2024, we had an opportunity to speak with Black and racialized immigrants and refugees with disabilities to understand their experiences before and beyond the pandemic. And I'm fortunate to have one of our lab members, Nadine, who led this study in the lab. And so what I want to share with you is some of the stories that we heard from Black and racialized immigrants and refugees with disabilities. I'm going to talk to you about how they navigated healthcare, social services, and the different types of supports that they relied on day to day. I want us to think about what happens as these individuals try to access these services, and what happens when these systems don't respond in a way that people need. What we heard weren't one-off situations. I'm simply just sharing some stories with you. There were patterns in how people were experiencing access, trust, and communication. I want to bring this down to what it actually looks like in people's lives. So I'm going to start with MP's story, and these are all pseudonyms. MP grew up in West Africa, and he described being really active, playing soccer with his friends, and spending a lot of time outside. After one match, he injured his leg. At the time, he didn't have access to care that could properly assess or treat the injury. The people around him, including his family, his community, they told him it wasn't serious. It's nothing to worry about. You're just being lazy. Over time, he internalized that. He believed them. So he didn't receive care early, and his condition worsened. He lived with that for years before coming to Canada, with the expectation that he would finally be able to access care and the support that he needed when he got here. When he arrived, he told us that there was not any clear pathway into navigating services. So he began to rely on his community to figure things out as he went. But when he later accessed healthcare in Canada, he described sitting in waiting rooms while others, specifically he mentioned white patients, were seen before him, even when they arrived later. So even within the system, he wasn't seen as a priority. This isn't about misunderstanding information, as MP told us. It's about how people's experiences are interpreted. I always like to think about who gets believed. The universal symbol for accessibility is a person using a mobility device. We know a large number of disabilities are actually invisible. So what happens if your body is not read as disabled, if you are not read as being in need? What MP's story shows is that when people are not believed, they don't get care when they need it. And when that happens, trust breaks, but long before communication even begins. So by the time COVID-19 came around, these experiences had already shaped how he understood and moved through those systems. He was more likely to rely on his community than he was to rely on any information he received in public. And this is Dee's story. Dee is a 25-year-old Black woman who was born in the Caribbean, and she came to Canada as a teenager. She uses a wheelchair after becoming disabled as a child. After that, she tells us that her social world changed completely. She lost friends, she experienced bullying at school, and eventually she left and continued her schooling online. Over time, she just stopped going to school. It's not that she couldn't, go to school, but she didn't feel safe going to school anymore. And those early experiences were already shaping how she moved through the world, how she read her body based on how other people treated her, and how she began to feel about herself. Dee had a really, really close relationship with her mom. And during the pandemic, when her mom became sick, they made the decision not to go to the hospital. Dee tells us that the hospital was packed. It felt really, really overwhelming, and it felt risky. One of the speakers this morning spoke about for people with disabilities that were hospitalized, when family members came to visit, those family members were not just there to visit, but they provided essential care support. Dee was afraid what would happen if she accessed or her mom accessed the hospital and they were not able to go see each other. So care didn't just become harder to access, it became something they avoided. Her mother later passed away after developing COVID and then long COVID. And in this story, what I want us to think about is that it's not about misunderstanding the information that was shared, available to the public, but it's about whether these systems feel safe to access. What Dee's story shows is that when systems don't feel safe, people disengage. And when that happens, communication doesn't land because they're no longer in the system to receive it. I'm going to share one more story with you, and this is AJ. So AJ is a Black man who immigrated from the Caribbean, and he lives with a mobility disability and ADHD. All of the folks we spoke with identified with the disabilities that they had. We asked them to, use the terms and words that make sense to them. Growing up, he had really strong family and community support, but limited access to specialized care. Coming to Canada, there was hope that systems over here, specifically the healthcare system, would provide that support that he needed. And eventually, they did, but slowly and with significant navigation and push on his part. So even before the pandemic, access wasn't straightforward. During the pandemic, those supports were disrupted. A lot of programs moved online or they shut down. Services became harder to access, and routines that helped him stay connected disappeared with no word, no communication, and no understanding of next steps. What remained consistent was not the system. It was not the messaging that, what was being shared online. It was his family and the community that he had over here. They were the ones who helped him to navigate, adapt, and continue. And again, in AJ's story, it wasn't about misunderstanding the information. It was about what people rely on when the systems that they're counting on are inconsistent in what is being shared. What AJ's story shows is that when systems are inconsistent, people rely on relationships. And that's been a big theme today. Before we think about trust, we have to think about the relationships. For me, I thought about who's in the room, who gets invited into these spaces, and who's left out. And that's where trust often sits, not within relationships, not within institutions, but within community. What I want to stress is that these are not isolated stories. As a community engaged researcher, I started my journey in community a really long time ago, almost 15 years ago, and the stories I heard have remained the same. But now I have a different platform in which I get to share these stories with you. These stories reflect patterns in how people experience these systems, including healthcare, support services, and the people they rely on for support. With MP specifically, we saw what happens when someone is not believed. With D, we saw what happens when systems don't feel safe and people begin to withdraw. And with AJ, we saw what happens when systems are inconsistent and people have to rely on relationships just to get through. So when we talk about trust, I invite us to think about who gets to make decisions in these moments of crises, remembering that trust is shaped over time through repeated interactions with systems that either respond to people or don't. I also think of myself as someone who is an immigrant to Canada and navigating the healthcare system with a parent that was ill. And my dad would never navigate the healthcare system until he reached a moment of crisis, even though we've been in Canada for over 30 years, because there was this fear of not being understood, even though our first language is English. So for what I want us to think about in what this means for communication is that communication strategies often assume that trust is already there. But I think we've really questioned that today. And I want us to think about, what we've heard so far, that trust is uneven. And for many people, it's already been broken. So when we focus on only messaging, we miss what's actually shaping how people respond. People aren't just asking us to think about, do you understand this information? They're asking, does this system work for me? Have I been treated fairly? And thinking about fairly, I want to think about equitably, and can I rely on this? Will I be harmed again? If we want, if we want to rebuild trust, we have to start with the systems. We have to start with looking at who it has been designed for, how people are treated within them, and then who gets to shape them. I really appreciated the previous panel in talking about the science table that was put together, who was invited to be on the science table and who was not. I think these honest conversations are needed so that we can plan for future emergencies and think about, who's not in the room just as much as who is in the room. And I just want to end by just saying that the pandemic didn't create these issues. I think it further exposed them. Within community, we've all felt this for a really long time. It's just with social media being what it is right now, many people were able to connect online and just share more about what they were going through. As we were also going through the pandemic, we also saw the rise of anti-Black racism. We saw the rise of anti-Asian racism. My colleague Wendy, Porch, and I were talking about how pandemics don't just exist in isolation. Emergencies don't exist in isolation. They intersect with other inequities that are happening. So as we think about trust, we also have to think about what else is happening within our world that's shaping whether or not people will access services. And this is I think it's my final slide. And I want to wrap up by saying that when we listen to the stories of MPD and AJ, it becomes clear these are not individual challenges, they're structural ones. And I want us to think about, again, how we design these systems, how people are treated within them, mistreated within them. That means designing systems where people are believed, where spaces feel safe, not just look safe or we have a safe space sticker, and where access is consistent, recognizing that access looks different for different people, and it means working with communities. Again, I appreciate the speaker earlier today that spoke about co-designing and co-building. In the disability community, there is this saying, nothing about us without us. And that means when any policies or practices or procedures are being created, it centers all people, not just those of us that are able to come through the front door. Because the goal isn't to make people more resilient, it's to make systems more accountable to the people they're meant to serve. Thank you. Okay, so I'm gonna transition back into moderator, and I'll take a moment. So I'm going to invite to come up Ty Cordeiro. Ty Cordeiro serves as the Director of Programs and Initiatives at ASAAP, the Alliance for South Asians Aid Prevention. He has been with ASAAP for 8 years, having joined in 2019 as a coordinator for the Men's Outreach Program, and has since contributed to multiple initiatives across the organization. I've got one more, and then we're going to clap for them. Vaibhav Sawhney is a PhD student in health with a focus on the ethical and equitable use of artificial intelligence in public health. He serves as a community engagement and health promotion coordinator at ASAAP. In this role, he works closely with South Asian Middle Eastern, and Indo-Caribbean LGBTQIA communities, supporting culturally responsive health programming, settlement services, and services for people living with HIV. Welcome.
Good evening, everyone. My name is Ty, and, well, everybody calls me Ty, and I'm the Director of Programs and Initiatives at ASAAP. I'm going to quickly just talk about the organization that we work for, though, because I'm sure a lot of you don't know the work we do. So ASAAP was born out of community activism a long time ago, over 35 years ago. Here in Toronto, our office is located in the downtown area. And why did we come into existence? So over 35 years ago, we had a South Asian couple living in the downtown area who both passed away due to AIDS-related illnesses. And that happened because they weren't able to access services due to language barriers and cultural differences. And that's how community activists came together, and with the help of ACT, which is the AIDS community of Toronto, ASAAP was born. Over the last 35 years, we started working predominantly with South Asian community members and clients, which then expanded to working with Middle Eastern community members and then Indo-Caribbean community members. We started as a small organization, but today we've grown strong to almost 20 employees or staff members that work together in different programs. We have 3 main programs as part of the organization. One is our support services, which is case management for people living with or affected by HIV and AIDS. We do have settlement services, which is funded by IRCC, that we've worked since the last 6 years. And we also have something called the Trans Power Project, which is for members of the trans and non-binary community members. That's how ASAAP came into existence. Now, we're going to talk about well, rebuilding public trust, community-centered focused health. I'm going to start off by expanding a little more from what Chavon earlier shared. So public trust, why did it break when it comes to the communities that we work with? We're looking at something a little more focused because we have the knowledge of working firsthand with with our community members and clients. So during the pandemic, the first thing that happened was a lot of things changed for the communities that we worked with. Okay, the first thing that went away was their livelihood. A lot of these people were newcomers. A lot of our clients and community members are newcomers into the country. They were working 2 jobs, 3 jobs just to survive. And overnight, when the pandemic hit, all of that went away. So we did have multiple people reaching out to us saying that we no longer have our jobs, what do we do? Clearly, at that point of time, it was chaotic. Not a lot of people knew what was going to happen. Everybody knew that we had to isolate. We knew that you could get COVID-19 by going out. So things changed drastically, and they changed overnight. So people lost employment, which then led to them losing accommodation. Because clearly, it is very difficult if you don't have multiple jobs to hold a house or a room in Toronto. This led to a lot of our clients and community members who are majorly part of the LGBTQ+ community to then lose housing and then move further on away from the city or move into actual unsafe spaces. Then the next effect to that was isolation, because when you move away, you get disconnected from the people that you regularly meet, you get disconnected from the organizations that you access services from, and that led to isolation. So it was a cascading effect where trust already got affected. They trusted the system to be employed, that went away first. They trusted that they could keep their housing, that went away second. And then all the people that they were connected to also moved away, or they got disconnected with them. So trust was definitely was affected in this situation. Now, when we talk about the response to COVID-19, the public health, and Canada's response, I would have to say that yes, Canada did do a great job as compared to the countries where our clients originally come from. So a lot of our clients, and mostly a lot of our people, were very appreciative. However, what we have to see is the efforts that were put in came with the notion that one lens fits all. And that was not correct or true, okay? What do I mean by that is when information was being put out for COVID-19, we automatically assumed that everybody was getting this information, was able to consume this information, was able to understand this information and follow instructions. But as marginalized communities, a lot of our clients that we worked with had very different limitations. Like, to start off with, one of the first things was we assumed that all this information could go out through internet and through smartphones. A lot of our community folk don't have smartphones. So obviously, if there were images that were being put out all the time, if there was information that was being put out all the time, which you can really easily get through WhatsApp or whatever on a smartphone, a lot of our community folk were not getting it. A lot of them didn't have laptops. A lot of them did not have access to the internet. So the information itself was not reaching a lot of these community folk. Second, language barriers. A lot of the information was put out in English and French. The information that a lot of our community members read or understand are not English and French. They would probably be speaking languages like Arabic, Farsi, Turkish, Hindi, Punjabi, Pashto, Dari. So the information was going out there, but nobody was understanding what was reaching them. Also, the imaging that was on it was predominantly to serve the larger populations, which is white imaging, or people who are white on those. For a lot of our community members, if they take one look at an image of that sort, they automatically assume that's not for us, right? So there was no cultural representation on those images. And so this in itself, it was very uneven, but we ourselves as an organization were actually trying to figure out how do we adjust to a lot of these things, because we were also grasping at straws. We had to figure out how do we take all that information that was coming in from public health, translate it, convert it to something that our community would respond to, and then put it out. So in that way, I'm going to say there was that trust that broke before, and this actually led to more limitations. So what is our response? Well, when we did try getting things into place and we started understanding how we did it, the first thing we did was translate all that information that came in. We translated it into multiple languages. We made sure that the images that were put on a lot of that, all those flyers and all those literature had cultural representation. And that's why organizations like ASAAP, ACAS, a lot of the aid service organizations are very necessary, because that's what we do. We take information, we know what the community requirements are, we change that information while keeping the content the same, but we make sure that it is specific to the communities that we serve. Now, unequal access to imagined communities, which is basically more in depth what I was just saying. So access reflected dominant narratives. A lot of the posters that were put in community buildings, that were put at hospitals, that were put at doctors' clinics, did not have the representation for a lot of communities. And that is why a lot of people took that step back and automatically assumed this information is not for me. It is not for us. A lot of them didn't understand the language. The language itself was very high, which probably, if English was your first language, or you're a medical student, or you're a doctor, or you're a nurse, you would understand it. But if you are a common person just flying in from another country and is still adjusting to the whole culture, is still learning English, that information would look like a foreign language to you completely, right? So another barrier that we saw, and a lot of this information that I am talking about today were experiences that we had and limitations that we spotted. Another limitation that we spotted is A lot of the information that went out pretty late, which was very specific to the communities that we serve, like the LGBTQ plus community or people living with HIV. Some of the questions that we constantly were trying to get from public health was, does the vaccines have any effects with people who are taking PrEP, who are accessing HIV medications? And that understanding came in pretty late for us ourselves before we could put it out there. And these are very genuine questions, because a lot of people were too scared to say, if I am going to take a COVID vaccine shot, is that going to affect the fact that I'm having PrEP every day? Or is this going to kind of somehow or the other have any issues or reactions with the HIV medications that I am on? Right? And we also need to understand a lot of newcomers that have come into the country and were living at that point of time over here may have not had their health card yet. So they probably were still taking HIV medications that they have bought from back home. And so it's not easy just to say that, oh, if you're taking this particular medication, yeah, that's no issue. You can take the COVID vaccine, right? We had to get them very specific information saying, this is the medication you've bought from back home. Yes, if you take the COVID-19 shot, it would not affect you, right? So a lot of that, there was a lot of varied, the trust itself was very varied. And when I say the trust itself was varied, yes, you did have a lot of people living in the downtown area, and we were able to get that information out to them pretty quickly. But what happens to those who are living in the GTA or in the suburbs or beyond Toronto? It was extremely difficult to get information out there. And I've noticed this several times, even when we do things like outreach. The information does get restricted to the downtown area. But beyond that, the information gets lesser and lesser and lesser the more further you go away, right? So when we talk about communication gaps, the first thing that I wanted to bring our attention to was it did lack language, and it did lack, languages that were culturally appropriate or would appeal to communities that were marginalized, and to imaging, which was not present at all. And then, of course, a lot of this led to a lot of confusion, because the one thing you need to remember is that when people are in these situations, and they're going to turn everywhere for information. So people were turning to friends, people were turning to family members, people were turning to colleagues, people were turning to people back home for information. Now, when you're getting different sources of information that are coming from multiple places, that automatically leads to a lot of confusion. And when that confusion happens, what are the decisions that you're going to take? How are you going to take the right decisions? Just sorting all that information out, it took us a lot of time to figure out, because we had to then approach nurses, doctors, community leaders, who people would actually trust from our communities. Because it was not just about taking that information and putting it out there. It was about making it accessible and believable to the communities that we work with. So I'm going to stop here and then leave it to my colleague Vaibhav, who's going to take it further.
I think when I think about ASAAP and COVID-19, the first challenge that comes to my mind is that work that we did in the past was very in-person, and to move all that into digital while maintaining the same challenge that people face, which is of not having access to phones, or how to navigate through a phone, was still very valid and still very out there. We did talk about public health being a positive approach, which basically means that it assumes everyone to have an equal say, equal opportunity in assessing services, in understanding information and all that, in policy making, in decision making, all that. When we talk about vaccine hesitancy, especially which we saw during COVID-19, and structural barriers, we think that we often frame it in a way of individual choice or misinformation. But for marginalized communities, hesitancy was also structural. For newcomers, Ty mentioned about how the information gets dissipated as we move farther from, let's say, this core downtown region. Immigration shaped access to healthcare in very different ways as well. People who have their permanent residencies, who are, let's say, on a postgraduate work permit, all have different levels of access to healthcare in terms of their health card. You need to have, let's say, some sort of work experience. Only then you have your OHIP insurance covered. And during COVID-19, when you know there was less work, and if there was work, there was only precarious work, these things become much more of a barrier in accessing services, especially with the vaccines. So that basically means that access to healthcare and vaccination were not equally distributed from the beginning. Public health responses often assume level of stability that many marginalized individuals simply did not have. At the same level, dominant public health narratives did not always reflect people from different social locations. This connects to the idea of imagined communities that we talk about, where systems just focus on or are designed along populations that align with the dominant national values and experiences. Immigrants usually are not in that narrative at all, or especially during the times of emergencies where resources are always less. We also saw structural contradictions. For example, Brampton was always considered as, or highlighted as, a place of hotspot for COVID-19 transmission, yet when vaccine eligibility came out, we saw that M postal codes were given more priority over the others. Another important factor was precarious employment. People who were involved in precarious employment could not afford to take the days off because a lot of hearsay was that once you take the vaccines, you get the fever in the next couple of days. And then finally, the pandemic also worsened public health outcomes because of the long wait times, which were already there, pre-existing conditions, which kind of, as Ty said, that it kind of intervened with the existing conditions of the people and access to health. Then comes the Mpox, which was more towards the next year of COVID-19 or the years coming after. The Mpox revealed very similar tensions and stigma around stigma, trust, and access because the outbreak gained visibility around pride events. Mpox quickly became or got framed as a queer disease. This reinforced stigma around queer communities and created fear around visibility and disclosure, especially for our communities, Semitic, LGBTQI individuals. These experiences became even more layered because sexuality, culture, religion, and community reputation are awfully deeply interconnected. We saw how public health messaging, even when attempting targeted outreach, can unintentionally reproduce exclusion or shame if communities are meaningfully not involved in the response. Another challenge was the vaccine sites are very limited, let alone thinking of them being culturally responsible, culturally informed. At ASAAP, we did organize these vaccine clinics, but then again, that also showed a little bit of challenge at hand. Most of the people that showed up were people who do not actually belong to the BIPOC communities, but more white. What does that say? That a lot of stigma was still there, even if you make the geographical location or even say that this is targeted for certain communities, it's still, the person has to show up there to get the vaccine or to show up for the intervention itself. So rebuilding trust, someone did talk about nothing without us, without being involved in that. At ASAAP, we've been working with GPA and MIPA, which is greater involvement of people living with AIDS or meaningful engagement of people living with HIV. And when thinking about rebuilding trust, I think one of the biggest lessons for us was importance of community-informed and collaborative approaches to care. Someone mentioned co-design collaborative approach as well. At ASAAP, we engaged in many community-based researches to better understand how COVID-19 affected Semitic communities, newcomers, LGBTQI+ individuals, and people living with HIV. These conversations were important because they shifted communities from being seen only as recipients of care to active contributors in shaping responses and identifying gaps. Within healthcare, COVID, as someone said, it also exposed long-standing inequities. It highlighted that systems were not designed for marginalized communities at all. And we did see, following COVID-19, that a lot of similar organizations reach out to us so that they could have mitigation strategies set up for further pandemic-like situations. And this could involve basically setting up or translating public health materials into multiple languages, improving sign-up and registration processes, and increasing language accessibility within healthcare settings. For example, setting up kiosks which have multiple languages and all that. For us, rebuilding trust also meant on focusing on aftercare and on continued engagement and collaboration. Socially marginalized communities are often later in accessing services, vaccine treatment, because barrier accumulates over time. Delays in care can also lead to more complex health and emotional needs afterwards, and that's what we did even after COVID or long COVID as we know it today. This demonstrated that trust cannot be rebuilt through information alone, but it requires sustained relationships, cultural responsiveness, and systems that communities can meaningfully engage with. And ultimately, rebuilding trust means moving forward from top-down public health responses towards more of a collaborative and community-based research or approach. We'll have questions at the end, I guess.
Great. Awesome, thank you so much. And thank you for reminding us the importance of recognizing that this one-size-fits-all lens, even that wasn't the intent, that's what it felt like in these communities. And the need to shift systems to meet the needs of the people, which is something we learned, I think, as the pandemic rolled out. Thank you for also highlighting different types of barriers that different communities experience, and the need for us to think about culturally relevant and responsive supports and services. And a small plug before I turn it over to Wendy, we're hosting something that is also funded by IHIP called Collective Futures Roundtables, where we're traveling across Ontario and we're bringing public health leaders together. Michelle Murty was one of the leaders that spoke at our Toronto Roundtable, and community organizers, people with lived expertise, as well as academics to talk about their experiences during the pandemic and how do we plan for future pandemics and public health emergencies. And we've created a zine. One of the zine is on the table. We're in the process of working on the second zine, and this is in Toronto, Southwestern Ontario. We just did that last week. We have one coming up in Durham, and we'll be going up north for our very last roundtable, and I hope we'll share that when it's ready. So now it gives me great pleasure to introduce Wendy Porch, who's the Executive Director from CILT, the Centre for Independent Living in Toronto. She's been working in the field of accessibility, disability, human rights, and education for over 30 years, and is a lifelong disability rights advocate. She started her advocacy work at Arch Disability Law Centre, supporting people with disabilities across Ontario. Welcome, Wendy.
Hello. I'm the very last speaker today. Isn't that the best spot to have, really? Can everybody hear me okay? At the back? Yes, okay, good. Thank you very much for having me here today. I've learned a lot. I've been reflecting a lot. Somebody was talking about PTSD. I think I've been experiencing some of that as well, reflecting on our time through the pandemic together. I am with the Centre for Independent Living in Toronto, also known as CILT. We've been around for 40 years. We are an organization by disabled people for disabled people. We work to provide services that give people with disabilities the opportunity to live in the community with dignity. It's not always an easy job, I have to say. So today I'm going to talk to you about something that we did in partnership with Toronto Public Health and with the City of Toronto to restore trust in real time for disabled people around vaccinations, COVID-19 vaccines. So it's the Accessibility Task Force on COVID-19 vaccines. Restoring trust in real time, I wondered whether I should make this a question. So we'll just hang on to that, and we can talk about it a little bit later. This is what I'm going to go over. I just wonder, how much time do I actually have, Chavon? 10 minutes? Okay. So in March 2021, the City of Toronto's Accessibility Task Force on COVID-19 vaccines was created to address a major equity gap that people with disabilities had not been explicitly identified, prioritized, or planned for in the early vaccine strategy planning, despite evidence, I think, of disproportionate COVID-19 risk and some significant access barriers. So we don't really collect great data on disabled people in healthcare settings generally. In other jurisdictions that were collecting this data, we could see very early on in the pandemic that there was a disproportionate impact on disabled people. In the US and the UK, we saw dramatically increased numbers of deaths amongst disabled people during the pandemic. In England, I used to live in the UK. I was actually a research fellow in the UK for a number of years. In the UK, we could see, where they were collecting this data, that early on, disabled people made up 6 in 10 of the deaths involving the coronavirus for the period up to November 2020. And for comparison, disabled people only made up 17.2% of the study population. We also saw some communities within the broad community of disabled people being more impacted. People with learning disabilities are dying of coronavirus at more than 6 times the rate of the general population. I should just qualify this by saying language is important. In the UK, when they talk about people with learning disabilities, they're talking about people with developmental or intellectual disabilities. So slightly different terminology there. These are some of the headlines that we saw in the news where they were tracking these numbers. Again, COVID deaths for people with learning disabilities in England were 6 times the average. And again, 6 in 10 deaths in England were people with disabilities. 2 more headlines. One is, Fury at Do Not Resuscitate notices given to COVID patients with learning disabilities. This was a thing that was happening. I don't know if everybody's aware of this, but when people with developmental disabilities, in this case in the UK, were in the hospital being treated for COVID-19, they were having Do Not Resuscitate notices attached to their files without their knowledge, without any of their family members' knowledge, which was clearly very shocking. And again, here's another article, The Devastating Impact of COVID-19 on Individuals with Intellectual Disabilities in the United States. So again, we were seeing very particular populations who were quite early on having been tagged or visible as having a disproportionate impact that COVID was having on them, but we were not seeing that in Canada because we don't really collect data about disabled people in that way. So for us, I am also a disabled person, as are most of the people that I work with. It was a strange time because it was a time when disabled people were both less visible because everybody was at home and we weren't seeing people and it was hard to really communicate, and paradoxically more vulnerable. The lack of visibility in system responses, so we eventually saw ourselves named as a community that people should pay attention to, but it took some time. The inability for people to bring support people to hospitals, we've heard about this a couple of times, but this was profound for our community members. So many of the people that we work with are people with physical disabilities who rely on attendants or personal support workers to get up out of bed in the morning, to be able to get dressed, to be able to eat. And being unable to bring somebody with you to the hospital meant that you would potentially not be able to eat. You would not be able to be moved. You might not be able to use the bathroom. The folks in the hospitals don't do those things, so being able to bring someone with you is critical. Also, these are communities that were unable to physically distance. So if you rely on an attendant to come and get you up out of bed every day, you can't physically distance from that person. They have to be they're in your space. And we actually were the provincial administrators for quite a large program called the Direct Funding Program that enables disabled people to be able to hire and maintain their own attendants. Overnight, we went from having a situation where everybody seemed to be fine to having more than 1,000 people across Ontario who had to have people in their homes multiple times a day to be able to live, and we had no PPE. None, absolutely none. And we went to the Ministry of Health and said, but we need PPE. They said, everybody needs PPE, get in line. So all of these systems, all of these impacts led to people being tremendously fearful. At the same time, I remember this very clearly. I was getting a lot of emails from the Ministry of Health, as were other executive directors of health service providers. I got a very innocuous email one day, and it really didn't say too much. It was just, what was going on in terms of infection rates. There was an attachment, and it was a triage protocol. And I read through the triage protocol with a growing sense of, I don't even know how to describe it. It was horror, I guess. It became very clear that the triage protocol was designed to be able to prioritize people in the event of there not being enough treatment for people with COVID-19. It also became very clear that the vast majority of people that I worked with, because they relied on another person for assistance with activities of daily living, would be deprioritized for treatment. And it's just sort of landed in my inbox in a very quiet way And upon reading it, it was quite horrifying, and we all became aware of this. So disabled people really were not feeling as though their lives were valued. They knew that their lives were valued in a different way. One of the things that we were advising people actually at the time, disabled people, many of them told us, well, I'm not going to go to the hospital if I get sick. I will not go. We said, if you do have to go, what we're advising you to do is to take photographs of yourself in your humanity, in your community. I think that was a Freudian slip. Pictures with your pets, pictures with your family members, put them in a Ziploc bag and connect them to yourself so that they will see you as a human being if they are having to make decisions about whether or not you get treatment. We truly gave people this advice during the pandemic. So when we're talking about trust in these kinds of systems, you can see how profoundly far back we were starting with this community. As I said, many people said they would not go if they were sick. They told us clearly that they felt they would be left alone to die. So the early engagement plans from the City of Toronto did not identify disabled people at all. I sat in on the very first meeting where we talked about the ambassador strategy, and they had great plans, and we were going to get local leaders, and this is how we're going to build trust. And I sort of said at the end of the meeting, but where are people with disabilities? You haven't talked about accessible communication. How are you going to serve people who use ASL as their first language? What about people who are neurodivergent and might not want to be vaccinated? How are we going to do this? So there was also no attention paid at that point to congregate care beyond long-term care homes. So there were many, many congregate care settings that housed people with developmental disabilities who were in constant outbreak. And I was showing you earlier some of the numbers that showed that this community was at a higher risk of dire outcomes if they were infected. And yet there was not very much attention being paid. And again, these other factors, reliance on personal support workers, the inability to physically distance, inaccessible booking systems, inaccessible clinic navigation. We were also concerned about other barriers for deaf and blind communities. Remember when we were telling everybody to distance? How do blind people distance? You know, how are you expected to do that? If you use sign language as your first language, how are you going to communicate questions about the vaccine if there are no interpreters? So these were the kinds of things that we were really concerned about. Also, just to say quickly, neighborhood-based strategies are challenging for this community because where do disabled people live? I have to tell you, somebody from the City of Toronto called me at the start of the pandemic and asked me that question. And I said, I'm just an executive director of a nonprofit. You're the city. Why don't you know where disabled people live? And it's largely because we don't ask the question. So, limited disability disaggregated data further contributed to invisibility throughout the pandemic and in planning for the vaccine rollout. So we formed a task force in March of 2021 to make recommendations to close these gaps, to share knowledge about COVID-19 infection risks, and to identify, review, and address concerns with COVID-19 vaccines and any barriers to accessing the vaccines. We worked very closely with some folks in the room here today, so Dr. Davila and Dr. Lamptey, thank you for your partnership in this work. We were also a mix of service providers, advocacy organizations, clinical and research partners, city staff, and significantly, people with lived experience were on our task force too. So here are some of the agencies that we worked with: Balance for Blind Adults, Silent Voice, which is an organization by and for deaf people, Safe Haven, Surrey Place, and a number of others there. I had the pleasure of chairing this task force. And we were supported by Social Development and Finance Administration at the City of Toronto and Toronto Public Health. So what did we do? We were able to come together and really quickly address one key concern right away, which was that these outbreaks that were happening for people with developmental disabilities. And we actually sat around a table and said, could we just not get some mobile vaccination teams out to these congregate care settings? And we had that happen within 1 week. I would say actually within about 5 days, having had the conversation, we were able to get mobile vaccination units out there. We made a number of recommendations to the Toronto Board of Health that were accepted, including elevating people with disabilities as a priority population. This was the first time we saw this happen. Directing accessible booking. We worked together to come up with a booking system that was accessible because the city's booking system was not accessible. How do you introduce accommodations into clinics? So we worked with Toronto Public Health and with the nurses and the staff at the vaccine clinics to come up with things like private spaces. So if you went to a vaccine clinic and you were able to get your vaccine in just a private space and you could lay down and have that vaccine provided, that was something that we worked with the city on developing. We also developed staff training and methods for accessible communication. We had 4 disability-specific clinics at the convention center, and there were more than 2,000 people that were vaccinated in those settings. We also established a vaccine accessibility cluster in the ambassador strategy. So we actually developed training that went to all of the vaccine clusters that were regionally and neighborhood located, so that the disabled people who live in neighborhoods and went to those clinics could also be provided with accommodations and thoughtful vaccination practices. And we continued with super supportive clinics into 2022. So just to say some quick lessons out of this work. Disabled people were not hard to reach, they were completely overlooked. And very often we are the last person at the table, last people at the table. The data gaps drove the inequity. When we don't ask the question, at the very least, are you a disabled person? Do you have a disability? We can't see the community. And when we can't see the community, we can't measure the inequity. And also, it would have been better if we had been involved in the strategy from the very beginning, because the retrofitting and the working backwards and the working under the additional time pressure cost more. We have to have an intersectional understanding of our populations. When we talk about vulnerable or marginalized populations, disabled people exist in all of those communities. So we have to think about intersectionality. And nothing about us without us can be operationalized. So disabled people at the table, we were able to say, well, you know, thinking about it, like, why do you need a diagnosis if somebody's going to come to this clinic? What we did, for example, around disability definition is we took the Ontario Human Rights Commission definition, we put it out in the world, and we said, if you identify with this, come here. You can access accommodations. We did not require complex questions to be asked. And finally, accessibility had benefited everybody. We heard from very, very many people, a huge number of people who had extreme anxiety around vaccination, who found the accommodations that we had developed, the quiet spaces or places where you could lay down and not even have to talk to the nurse, to be the only way that they could be vaccinated. And so this is just an example of a curb cut advantage for everybody else. Was trust restored? I'm not sure. You know, we saw that triage protocol. Many, many people with disabilities told us, you know, we suspected maybe we weren't valued before the pandemic, and then the triage protocol kind of proved it to us. And what we hear from community members still is the expanded MAID eligibility. So now if you have a disability, even if it's not something that you're going to die from, Track 2 MAID eligibility means that you can access medical assistance in dying. And for many community members, it feels like, why does our community have more opportunity to access death than supports for living with dignity? So, very challenging context for our community to live in. Also, just to say one final thing here, is that disabled people have always existed. We've always been around. We will continue into the future. And so when we're talking about future planning for pandemics, if we're not also talking about having this community at the table, we are destined to repeat some of these mistakes. So, thank you.
So thank you so much, Wendy. I'm going to invite
all the panelists to come up. I think we have time for one question or two, but we will be here. Some of us will be here after. So if I can invite the panelists up, and Wendy, thank you for showing us what coalition building looks like when we bring diverse disability community with public health leaders together. Okay, I've been told we have time for 2 questions. But we'll be here after if folks want to talk. So I'm gonna turn it over to the audience first. Now's your chance. Okay, we've got one question.
I was hesitant to raise my hand because I've asked a few. I think so I wanted to go to the research from Colin. I find it really interesting having been in the field as a head of emergency operations. A lot of what you say aligns from a practical lens when we look at expertise and leadership. The one thing, I'm not sure if it's a question or kind of something to offer, but there is an element there about the more we ask from that kind of adapted expertise group, the more self-care may also need to be embedded in. So the idea that we're looking for, it sounds like from the research that's kind of the model of where we want to go, is having a lot more adaptive expertise, but there is a lot of pressure then on that group to know so much. And when we hear the presentations today, it's not about that adaptive expertise being the expert in all those areas. It's about being able to access kind of that expertise. And you touch on that. It's how do you think, how do you respond to your environment? But I do think there's a component there for like considering the mental health aspects of what it is to be an adaptive expert. And the more we push that, the more we have to think about kind of supports for that expertise as well. I'm not sure if that's something that came up in your research.
Not so much yet, but that's really resonating for me. And I could talk for hours on this, so I'll try not to. But developing abstractive expertise takes time. And people who are in frontline positions, who are in senior positions, who are in healthcare professionals, aren't given that time. If you look at the whole education scheme, I mean, it's like, sure, let's make lots of space in healthcare education for this. No, that's not there. So, mental health is one way to go about it. The other is just like being human in terms of how we approach our work and how we develop mastery. And I really wish we could redistribute how time gets allocated and spent, and we have more resources. Because yeah, it's an obstacle. It's no question, it's an obstacle. So thank you for that.
Thank you. Thank you. We have time for one more question. Okay, 2 questions. You've got one? Okay, Nelson has a question.
I've got a final word. So actually, for the experts here, how should we be communicating uncertainty during times of trust? It's a big question, but I really love to hear your thoughts.
Okay, so the question was, how should we be communicating uncertainty?
Uncertainty, yeah. Basically saying that we're not sure.
Okay. I'd like to turn it over to you folks first, if that's okay.
Okay. That is the subject of a book I'm writing. Because during the pandemic, science was evolving, we needed fast science, knowledge was provisional, and very often we felt the need to communicate confidently, and that's kind of the World Health Organization sort of position, confident messaging, business style. And sometimes our communications overreached, and they had kind of a rebound effect on people. Vaccines are safe and effective, messages about masking, messages about boosters. Often this came back to bite us later when there were reversals, as we found out, got more information and the bigger picture. So, it requires kind of a different way of thinking about our relationship with the public, because it's an ethical issue, developing strategies to communicate uncertainty. Israel, as I mentioned a couple of times, Israel did, and Nordic countries did this really well, right? And really brought the public in as kind of co-creators and partners of strategies, communicating all the way along, like we're trying to find out stuff. This is why we're launching this massive vaccine campaign in Israel. Right? So it's, you know, it's kind of a new frontier for us to think about our relationship with the public.
I think it's such an interesting question, and you know, reflecting on what would be valued from the perspective of working with disabled communities. You know, our community sort of knows what things can look like when things go wrong, kind of inherently. And I actually think that communicating uncertainty transparently could enhance trust and credibility. I think there's something to be said here from our perspective about the medical model, right? So as a disabled person within a medical setting, you're usually a problem to be solved, you know, and that has pushed people away. And I think embracing and authentically being transparent about uncertainty would, for our community, make it feel like a much more authentic relationship. I think that would be a better place to start, frankly.
Thank you. And from the stories that we heard from the people we spoke to, they said the same thing. Number one was transparency. If you don't know something, just say so. We're all going through the pandemic, and sometimes we can forget that those that are leading us through the pandemic are also navigating it to the best of their capacity. So at our roundtable conversations, the public health leaders in the room spoke fairly honestly about that and named the challenges, the complexity, and what they're hoping to do in the future. So I think the conversation that we're having today is really important. And in thinking of honesty is also having humility. As we do this, people are not expecting you to have all the answers. They're just expecting us to be honest.
Just to add to that, I think also when we talk about transparency, sometimes even if we to speak rigid of the stuff which is actually out there, the facts, sometimes that also leads to social panic, especially in times of health emergencies. So something could be saying out loud both the situation at hand in terms of what we have already achieved in terms of interventions, but also what's not being done right now. I think both needs to be set out equally rather than just saying the negative effects which are happening right now.
Can I add one last thing? There's a little bit of research about this. So if you're the person who's supposed to know the right answer, you're the scientist, and you say, I don't know, that doesn't go over very well. But if you are a lay expert, if you're from the community, if you are someone who is educated and engaged and interested and motivated, and you say you don't know, that's actually credibility building. So so the characteristics of the messenger, I would push the scientists to the side when we have uncertainty and have other voices. And I think that's the way for that to be heard without the reaction of, well, I don't trust science, I don't trust vaccines.
Thank you. I think if we don't have any more questions, we're going to wrap up. I want to thank all of the panelists so much for sharing your insight.